We're here at the IAS meeting with Rosemary from Waki Health, and you're based in Nairobi,
Kenya, yes.
Nairobi, Kenya, but you're from Cape Town.
So I'm from Nairobi, Kenya, and that's where I'm based.
But the
office
organization
is in Cape Town.
Right, the offices are in Cape
Yes.
Town, right? All Africa. So.
All Africa.
Okay. But you're here, you just completed a press conference, and your focus was talking about the issues around getting out the message of combining treatment of TB and HIV. For God's sakes, let's get it together.
Yes.
So pitch us on that. It's really important. How important is it?
Yes, so I was talking about integrating TB and HIV and providing the calling upon policymakers and leaders, African leaders, world leaders, to provide leadership and direction around a more aggressive way of integrating TB and HIV, and to translate policy into practice, because yes, we do have policies, we do have strategies around how we can integrate TB and HIV, but the implementation of that then translates that goodwill into actual practice is what we are missing. This is important because we have seen how the synergies between TB and HIV are very strong. TB is a leading killer of people living with HIV. In Kenya, for example, we have about 70% of this co-infection, TB-HIV co-infection. So about 70 people living with HIV are also infected with TB. Actually, about 70% of people who have TB actually also have HIV. And so because of that high prevalence of TB-HIV, then we realize that the synergies are very strong, and there is need to now not only just address HIV, which is what traditionally most countries and most governments have done, but we've seen over the last couple of years a more targeted approach where there is more desire, more leadership, but it is not to a level that is actually going to end the epidemic. So what we are saying is that if you're going to end AIDS, if you're going to end TB, we must stop looking at these two in isolation, and the two must come together. We must understand the science that makes the synergy strong. We must understand how prevention, when we take the two together, how we can leverage on that kind of prevention. And so for me, it's really about saying the time is ripe now. We have isolated the two for a long time, and the couple of years where we've been trying to bring the two together, there are efforts, but they are not to the level we want.
You have a lot of doctors that are visiting hours for TB is such a day, and HIV is another day. Was that what you were saying?
Yes.
Yeah.
So people end up going in for so many different appointments.
It's wasting funds.
Yes.
The doctor needs to know that they're both HIV and TB infected, and that they can address it either separately or collectively, but the same physician needs to address it.
Exactly. For example, if you diagnose a new TB infection in a person, for example, it is effective in terms of cost effective if you go the extra mile and actually counsel them also for HIV, for the chances that they might actually be also infected by HIV.
So sometimes they don't even know.
Sometimes they don't even know. They don't even know. And so if you do the diagnosis and you identify a new TB case, then it is encouraged and more cost effective to take an extra step to provide, to even begin to provide the counseling for HIV, and even encourage them to take a test.
So where is the disconnect? Is it the information to the patient to say, "Doctor, I am HIV and TB"? And then you just say that, or is it just that they don't want to know for whatever reason? It doesn't make sense to me.
It is two ways. In some situations, we as consumers, or when we present ourselves as patients, we don't always know what to ask for. And so that means there is quite a bit of work to be done among communities so that we are aware that when we present ourselves to physicians, we can ask for A, B, C, so that we know if I'm diagnosed with TB, I need to ask for an HIV test or HIV counseling at the minimum. So a lot of work has to go into community awareness, community education, but also healthcare professionals. They also need to be prepared. They also need to be encouraged. And they also need to actually take the initiative that if they identify a TB case, that they take it to the next level and begin to offer counseling for HIV, testing for HIV, and ensure that the particular person who have presented themselves actually knows where they stand with this. But one of the challenges, because you've asked this, is that investments in TB HIV are not to the level that they should be. So at the community level, the desire is to actually spread more information, sensitize communities. But sometimes we don't even have the resources programmed for this kind of work. So you find where education should go, where communities should educate communities, that kind of empowerment or facilitation is not present.
Because I think it's so important to let the patient know that it is going to be very much more helpful for them to be treated with both of those diseases in mind, as opposed to pretending like they have one to the one doctor and the other to the other doctor. It doesn't make sense.
Yeah. So that kind of empowerment is needed. On the part of the physicians, then there is also need for capacity strengthening among healthcare professionals. As a physician, if you are a physician, you might actually be aware, you might be willing, but you might actually not really know how to go about it because your specialized training is on HIV. You have no, and you, as a physician, you generally understand about TB, etc. But there are certain technicalities to it as well. And so investing in also healthcare professionals, ensuring that we are expanding their capacity, we are investing in ongoing training for healthcare professionals is also important. And
getting that piece of it in there, in that curriculum, is going to be critical.
Exactly. And once you get that piece in terms of the curriculum, in terms of capacity strengthening, in terms of investing in communities, because they do most of the work actually at the community level, whether it's door-to-door case identification, whether it's a follow-up, it's the communities actually are the foot soldiers for this response. So investing in communities, investing in healthcare delivery system, but also now investing in the commodities, because once you identify the cases, if it's TB patients being screened for HIV and you identify that they're HIV positive, you need to link them to care. You need to link them to treatment. You need to start them on ARVs. And so there are ethical issues when you actually enter into massive case identification and HIV testing and then be unable to link them to treatment. It seems futile to me.
So you're not able, there's not as much drug available as there are patients in need of it. Is that what you're saying?
Yeah, so what I'm saying is that we also need to be prepared and ensure that we have the commodities, the treatment, the ARVs, so that as we intensify the case finding, as we intensify HIV diagnosis, then we are also able to link any new cases to treatment and care.
And then let them know that it's very important for them to get on treatment for their own case, for their own reason, as well as this country reason.
Yes, exactly.
Do you have post-test counseling for those who test negative?
Yes. There is post-test counseling for those who test negative, because we always say if you're once negative, it's not a guarantee that you'll always be negative. So you're also prepared to say, if you're gonna wanna stay positive, negative, these are some of the things you could consider And really just knowing life is a journey. Today you're negative, tomorrow you could be positive. So that kind of guidance, that kind of counseling, that kind of support, even for negative clients, is very important.
So I really appreciate you taking the time with us. It's very, very good that you did this.
Yes.
Because I think we covered a lot of issues.
Okay, great.
Thank you very much.
Thank you.